So now we are starting about second part of GIT, that is hepatobiliary and pancreatic surgery. So let's see about the anatomy of biliary system. So here you can see this is the important thing which you have to remember in your mind. The hepatic ducts, basically right and left hepatic duct is smaller one, they join together to form common hepatic duct. So if you see, these are this is one left hepatic, small one. They join together to form common hepatic duct, and here is the gallbladder. This is joining to common hepatic duct to form a common bile duct, and it's opening. This is the duodenum. This is the ampulla. It's opening in the second part of the duodenum. Pancreatic duct joins with it to form common duct. Now here you can see this is about most commonly asked question. This is right and left hepatic duct to form common hepatic duct. Then there is cystic duct, and this is the base of the liver. So liver above, common hepatic duct and cystic duct, they form this scaled triangle through which passes the cystic artery. There is the common hepatic artery, right hepatic artery, left hepatic artery. This may arise from any of these common hepatic artery to form the cystic artery. So what are the common investigations done for the biliary system? Magnetic resonance cholangiopancreatography. It is magnetic resonance imaging that produces dilated images of hepatobiliary and pancreatic enzymes. So here what you do, it is a non-invasive, non-intervention. You just inject this and take pancreatic. So the same thing, the anatomy you are able to see. This is the common hepatic duct. This is cystic duct joining together to form the common bile duct. Here is the pancreatic duct opening the second part of duodenum. So this is MRCP, magnetic resonance cholangiopancreatography. This is cholangio, this is pancreatography. Here biliary radicals are kind of seen. And what is ERCP? Endoscopic retrograde. You are putting a duodenal endoscope, then the side weaving endoscope. You are passing a small this side weaving camera in this, and this you push the dye, or you just visualize it by using special endoscope, introducing the GIT till the duodenal papillae and cannulate it, tiny catheter to the common duct system. Injection of contrast while X-rays are taken. Contrast allows doctor to see the ducts. Benefits are the sphincterotomy. You can do the sphincterotomy here. The gallstone removal can be done. Stent placement can be done from this ducts. So what are the complications of this? It can lead to you're trying to cannulate it. So these are the benefits. You can do sphincterotomy, removal of the gallbladders can be done, and stent placement can be done through this. And complications are pancreatitis can happen, can occur, duodenal perforation, can occur while cannulating this, and bowel perforation can occur. ERCP can produce percutaneous cholangiography. You have to put a needle from here and cannulate and put this CT guided. It can be done. Biliary, and then put the dye from the biliary radicals. And if there is some obstructive tumor here, that is called as class 10 tumor, they will not pass below. So all biliary radicals are needle injected contrast into right bile duct. So this was about different types of investigations. So coming to gallstones, up to 12% of the men have gallstones. In the patients subjected to surgery, 12% will have common bile duct stones. 24% of the women and 12% of the men have gallstones. Patients subjected to surgery, 12% will have common bile duct stones. So what are the different types of stones? That can be cholesterol, single radiolucent, single large stone, increased cholesterol. Pigment type of stones are either black or brown. There are multiple stones, and brown stones are generally infection, and black are because of hemolysis of the hemoglobin, this hemolysis of the blood cells. When you suspect the patient may have stones, you must proceed for first is abdominal ultrasound and liver function test. So gallstones you are suspecting, liver function test will give you the idea whether there is raised bilirubin or obstructive symptoms of the common bile duct process, and that it has to. If the patient has ultrasound, the next step will be to require to do liver function test. This is the question asked most of the time. Ultrasound is done. Next step is not suddenly go further. You have to do liver function test to rule out jaundice, obstructive jaundice, alkaline phosphatase. Most of the time they are increasing. Alkaline phosphatase are increasing obstructive type of jaundice. If the patient has a elevated liver function test, enzymes, bilirubin, you must proceed for MRCP. This is MRCP. So MRCP is magnetic resonance cholangiopancreatography. So as it is increased, so you have to know for where is the site of obstruction, you have to find out. Or intraoperative cholangiography. During surgery, you have to put CBD is there or what. So clinical picture when there is gallstones, asymptomatic, symptomatic gallstones, complicated. There are three different types. Asymptomatic, if it turns to be complicated, or symptomatic gallstone turns to complicated gallstone disease, then you have to do further investigation. Biliary colic, cholecyst can be, clinical picture can be pain in right upper arm, repeated attacks, liver function normal, TLC increased, diagnosis acute cholecystitis, go for laparoscopic cholecystectomy. Due to any stone that can migrate, it can lead to migration of stone, cholangitis, obstructive jaundice, pancreatitis, gallstone ileus. So biliary colic, colic abdominal pain worse postprandially and increase of fatty meals. This is the main hallmark. Fatty meals causes severe pain. Antispasmodic gallstones prepare for delayed elective laparoscopic cholecystectomy. If antispasmodics initially, if gallstone, prepare the patient for cholecystitis. Patient is having acute cholecystitis. Here there are repeated attacks, acute right upper pain, fever, Murphy's sign is positive, mildly increased liver function test, ultrasound has to be done, laparoscopic cholecystectomy within 48 hours. So this is called as early cholecystectomy. Chronic cholecystitis, repeated attacks, then you have to go for delayed, conserve first and then go. Abscesses, positive history of right upper quadrant pain, swinging pyrexia, patient may systemic LVL, imaging, ultrasound, CT scan. Treatment is unfit patient, percutaneous drainage, fit patient, subtotal cholecystectomy, needed if cholesterol hostile. Contradiction to laparoscopic cholecystectomy, or if you are using laparoscopy but may change to open, unfit patient, implyma, previous abdominal surgery, difficult anatomy, callous triangle. Complication of migration of the stone, these can cause pancreatitis, then cholangitis, the what is jaundice, fever, right upper quadrant pain. Person is having fever, he is jaundiced and upper quadrant pain. Patient with cholangitis, severe sepsis, bad condition, fluid restoration, antibiotics, correct coagulopathy, then ERCP, put the stent. Gallstone ileus, move gallstone in the small bowel leading to interstitial obstruction. This has passed somewhere here, it is obstruction. What you will do, there is fistula from the gallbladder, CBD into the, then what have mechanical obstruction, terminal ileum anywhere, pneumomelia. So what happens, X-ray, regular stride, pneumomelia, air in the biliary tract, small bowel obstruction, ectopic gallstone. Laparotomy, enterotomy is done, the stone has to be removed, obstruction is relieved. Proximal to the end of site of obstruction, remove the gallstone. Plus, don't interfere with the fistula between gallbladder and duodenum. They already don't remove. There is no need of cholecystectomy. Acalculous cholecystitis, where there is no stone but still patient is suffering from cholecystitis. Patient may complement manifestation of cholecystitis, severely ill. Chronic illness like diabetes or organ failure. Patient systemic unwell, septic shock, gallbladder inflammation in the absence of stone. To answer the question, they need to clear the recommendation of ultrasound result without stone in the gallbladder. Treatment if patient is fit cholecystomy, unfit percutaneous cholecystostomy. So unfit patient, you have to relieve the compression, relieve the contents. Porous cholecystectomy complication. What happened? The bile leak more common due to cystic duct clip. If you have clipped the cystic duct clip is it has slipped, so it may lead to first investigations. Ultrasound, polycystic syndrome, typical symptoms like preoperative conditions, fatty food intolerance, flatulence, indigestion, intermittent episodes of abdominal pain, no fever, peritonitis. Post-cholecystic syndrome can present early in case and post-operative symptoms. So, as we have seen the anatomy, what is surgical jaundice? This is an obstructive type of jaundice, cholangiocarcinoma. So, anywhere malignancy there in this, cholangiocarcinoma of the ducts. Pancreatic cancer, they obstruct at this level. Liver metastasis, They can obstruct these biliary radicals. Cholangitis, any inflammation, this may lead to Mirizi syndrome from the gallstones. The CBD and cystic duct, they are attached to each other, so that cause obstruction. Injury to common bile duct while surgery. Prolonged use of total parental nutrition may also lead to uh, treatment of the cause is cornerstone management of relief jaundice. Patient with unrelieved jaundice much higher incidence of septic complication, bleeding, cholangitis, and death may occur. Therefore, treatment of the cause cancer, pancreatic cancer, liver metastasis, lymphadenopathy. If there is chance of resection, if you can able to resect in future, put a plastic stent. There is no chance of metallic stent. ERA stent if failed percutaneous cholangiography. If the ERCP is not possible, you have to put percutaneous cholangiography. General sepsis, total treatment the cause. Cholangitis, medical treatment with ARCP. CBD injury during cholecystectomy, what you have to see, perform ERCP immediately, place a drain plus consult hepatobiliary surgeon. This is the thing, you have to put a drain consult perform ERCP. Cystic duct leakage, you can put a sphincterotomy and stent with ERCP. Injured CBT, repair you have to done. Excised CBD hepatic jejunostomy you have to do. Mirizi syndrome definition is defined as common hepatic duct obstruction causing extensive compression or impact stone in the cystic duct from the infundibulum Hartmann pouch. Compression of the bile duct. In severe cases, then progress to fistulation. If your process for surgery, it will be extremely difficult as callus triangle is completely operated, risk of injury is there. So management Mirizi syndrome is ERCP plus cholecystectomy. If residual CBD stone, intraoperative cholangiography has driven CBD explosion, removal on the T-tube. Biliary cirrhosis. What is biliary cirrhosis? Primary biliary cirrhosis, PBC. Formerly known as primary, it is disease that harms liver ability to function. The bile ducts become injured, inflamed, inflammatory, permanently damaged. Patient BBC, no symptoms are listed, some patient discovery, and the doctor tells them long condition of obstructive jaundice, itchy abdominal pain. Antimitochondrial antibodies can be seen, and liver biopsy has to be done. Coming to the next topic about liver. So, what are the different types of cysts in the liver? Polycystic liver disease. It can be autosomal dominant, just like polycystic kidney. There can be polycystic autosomal dominant. This is about them. Then hydrated cyst. Hydrated cyst is causative organism. Can be, you can see, this is hydrated cyst. So, causative organism Echinococcus granulosum, most common in the sheep farmers, surrounded by intense fibrotic reaction which may calcify on city and daughter cysts are seen, may be connected to biliary system. Clinical feature asymptomatic. If it is more than 5 cm, it becomes symptomatic. Start with malaise, right upper abdominal pain, morbidity, cyst rupture. If it is there, it has got highly anaphylactic reaction and classical type of biliary colic, jaundice and urticaria. Here there is urticaria. So investigation. If you ask the history, the patient may be giving history of itching, urticaria, and rashes on the body, and this type of cyst. Ultrasonography may show septa, hydratis, or daughter cyst. CT scan investigation size from amebic lab may show elevated liver enzymes. Eosinophilia is there. Conservative management, anti-helminthic treatment should be given alone, not an ideal treatment for disease. Percutaneous drainage is safe. For cyst is very small. Radical surgery pre and post embryo administration of albendazole. Albendazole, actually, this is the treatment of choice. You must take care of cyst wall and so liver abscesses basically because of E. coli, Klebsiella pneumoniae. Pyogenic and amoebic is Entomia histolytica. Entomia histolytica is amoebic and E. coli this. So you will see for pyogenic now. It is endogenous from the bloodstream, old age, diabetes mellitus, multiple, subacute, any segment, leukocytosis, and fluid shift to the left is there. Ultrasound will show multiple fluid, USG guided respiration, antibiotic, most common. Enterocolon histolytica through GIT, through portal vein, young age group. There are single and they give aspiration still anchovy source of pus. This is called as and metropolitan are the treatment of choice. What are the liver tumors, lesions? The hemangioma. This is very common, most common benign tumor. Males are more common, huge called cavernous hemangioma. Discovered in cellular imaging, ultrasound, hepatic lesions, CT, MRI, increase alpha fetoprotein, mild transmission reported. Management watchful waiting is there. What is liver adenoma? It is a benign tumor, proliferative of hepatocytes. Most common in females, most common oral contraceptives. Tumor is well demarcated. CT and MRI are diagnostic. Hypodense tumor markers beta HCG and alpha fetoprotein exclude malignant transmission. Two major complications: rupture and symptomatic masses may be resected. A rare malignant potential. So malignant liver tumors are divided into primary liver tumors, secondary and primary liver tumors include. These are hepatocellular carcinoma, cholangiocarcinoma, angiosarcoma, hepatoblastoma, sarcoma, lymphoma, carcinoids. Hepatocellular carcinoma predisposing factors are cirrhosis, chronic hepatitis with B virus, C virus. These may cause hepatitis B and C adenoma. They cause hepatitis. Alpha fetoprotein and AFP and beta HCG are increased. MRI scan, biopsy has to be done. Any patient begin to elevated. Cholangiocarcinoma is second most common. It's because of bile duct CA9199, CEA, and CA125 are elevated. This is also called Clark-Stein's tumor and cholangiocarcinoma. Angiosarcoma of the liver, one of the usually types of PVC workers. So coming to pancreatitis, biliary lithiasis, increased bilirubin alkaline phosphatase. Alcohol consumption is the commonest cause post-ERCP trauma. Pathophysiology, when there is abnormal activation of digestive enzymes. Most common enzyme activity trypsinogen. So this is the main common enzyme. Activating digestive inflammation edema, the result in peri-fluid collection, saponification of the fat. Clinical picture, mild to moderate continuous pain in the abdominal pain radiates to back. Pain relieved in sitting and leaning forward, tachycardia, hypotension, laboratory, and serum amylase and lipase are here. And this is the question: test is serum amylase and lipase, and CT scan. General management is IV fluids, analgesics, antibiotics. Use of octreotide. This is one of the question. Octreotide can be used. Nutritional support has to be endoscopic. There is surgical management is delayed cholecystectomy. Acute fluid collection inside the pancreas leads to spontaneous development of pseudocyst. This is one of the question. Then pseudocyst is can be defined as pancreatic enzyme, blood and necrotic tissues. Sequelae of the acute pancreatitis. 75% contains high amylase. So management take time to allow pseudocyst to mature. It may take 12 weeks, 50% spontaneously, and acute can cause compression of the organs. So different surgery, open surgery, cystogastrostomy can be done. Cystoduodenostomy can, Roux and vaginectomy. You must suspect pancreatic necrosis when deterioration of general condition. So if the general condition is deteriorating, you have to go for once diagnosis. This is important. Final respiration, cytology, and culture has to be done. Sterile in necrosis, it means necrosectomy. Early necrostomy also with high mortality, so avoid. Infection, necrostomy is indicated when there is positive for infection. Pancreatic abscess occurs as fistula, hemorrhagic pancreatitis due to erosion of the blood vessels, splenic vein thrombosis. One of the serious complications that occurs after pancreatitis is pancreatic splenic vein thrombosis. What are the different pancreatic tumors? Beta cell secrete insulin, so it could cause increase insulin in that manifestation of Whipple triad. The fainting is there, hypoglycemia is that which can be improved by glucose. This is Whipple's triad. Decrease serum glucose, increase C peptide. This is C peptide and proinsulin. So in this increase, enucleation of the lesion. Glaucoma is AAG. A cells secrete glaucoma, it secretes glucagon. Glossitis is there, stomatitis is there, necrotizing migratory erythema is there. VIPoma, vascular peptides, watery diarrhea is there, hypokalemia. Again, Zollinger syndrome, gastrinoma, gastric secretion cause increased gastric hydrochloric acid. The malignant tumors of the pancreas, chronic pancreatitis, diabetes mellitus, they lead to BRCA2 mutation is also has got significant. Origin tumor is ductal epithelium. It is ductal epithelium. Gross site tumor of head represents 75 and body until is 25%. Ductal adenocarcinoma. So adenocarcinoma of the pancreas there you can see tumor arising anywhere. It may lead to obstructive type of jaundice. Early cases, duodenal obstruction, vomiting, abdominal due to involvement of afferent sensory fibers, and the constitution symptoms, weight loss are there. Tortious sign, Margati thrombophlebitis, palpable supraclavicle, all called as Virchow's lymph node. So this is ancestral Mary Joseph nodules, peritoneal nodules. Kuvitz's law is what does it says? If there is palpable smooth right upper quadrant maze, development of jaundice, then suspect of malignancy. While chronic cholestasis, gallbladder is not enlarged. So pancreatic malignancy, CA99 is a tumor marker. CA can be increased. So this is for the pancreatic malignancy. And what do you do? Histopathology in pancreas, FNAC is indicated only tumor appears unresectable for confirming the biopsy. Vitamin K should be given to correct coagulopathy. Low molecular heparin should be given. Bile salts and lactulose should be given to reduce introduction. CA head of pancreas, Whipple's pancreatomy. So what are the things which are resected here? You can Whipple's pancreas, obstruct jaundice. So if there is inoperable, you have to just put a stent, and in this you remove this common gallbladder is removed, cystic duct is removed, common bile duct is removed, this total head of the pancreas is removed, and stomach pylorus is removed, and you anastomose this pancreatic neck to the small bowel which is resected, and then another anastomosis of the common duct to the small bowel. Then you anastomose the stomach with the small bowel. So 1, 2, 3 anastomosis is done. This is end to side hepatojejunostomy. This is pancreaticojejunostomy. This is gastrojejunostomy. So jejunostomy at the end. Jejunostomy place. Feeding jejunostomy can be done. Complication of this: pancreatic head, primary side, duodenum, gallbladder, common bile duct. These are the things which is removed. Pancreatic head is removed, duodenum is removed. So duodenum is removed means that this drainage and this drainage is already gone, so it has to be started with the common bile duct is removed, pancreatic small bowel, regional lymph nodes, sometimes stomach pylorus. This is Whipple's operation. So this was about hepatobiliary system.